Type your questions into the text field and hit send. Keep the drop-down option as all panelists. Today's presentation is updates to the Simcyp simulator's oral absorption, atom, and M-atom models. Our speaker for today is Dr. David Turner. He's currently a senior principal scientist at the Certara UK Simcyp division, where his focus is on the physicochemical aspects of PBPK modeling. He's also the lead scientist on oral drug absorption. David is also serving as a PI for an FDA grant on developing modeling tools for handling supersaturating drug products. He earned a bachelor's degree in biochemistry and a master's degree in computer science, and then went on to complete a doctorate in chemoinformatics and QSAR modeling. David, welcome to today's event. I'll now turn it over to him to begin the presentation.
Susanna. Hello, everybody. If you could bear with us a moment because I can't forward the slides.
Hey, Dave. If you want, I could just forward them for you.
Okay. So could you move forward?
Yep.
Thank you. Sorry for the delay with the slides. Today I'm going to talk to you about recent additions to the mechanistic absorption models within the Simcyp simulator. I'm going to describe the main new models in varying degrees of detail because I cannot describe everything. I will also talk a bit about some of the tools or wrappers that we put around these mechanistic models, such as IVIVC, VBE, sensitivity analysis. I'll touch on strategy that we recommend, which is essentially the coupling of PBPK modeling to in vitro experiments and the modeling of those experiments. I'm then going to give a couple of examples which make use of the new tools. One of these is some initial work that we've done with Tacrolimus amorphous formulation in the area of VBE, and to answer the question as to what extent crystallization within the stored ASD may lead to bioinequivalence to the original formulation, the fully amorphous formulation. The second topic I'm going to touch on in some detail is excipient solubilization and tools that we've added to deal with this. One of the questions that arose from one of our pharma clients was, why did formulating with a cyclodextrin reduce the exposure of their compound when the opposite was expected? And I'll also describe how you can use the tools to assess the optimal amount of cyclodextrin to use in a formulation where there is an interplay between solubilization and permeability. I will cover in brief the new salt and surface pH models, surface pH for fine particle dissolution. I will summarize, and then at the end we will have a question and answer session. Next slide, please. Central to the major additions, recent additions to the atom and M-atom models is the particle population balance model. This model is mechanistically able to well account for both particle balance within the modeling system, within the GI tract, and of course also mass balance. Coming with this are various other additional benefits which have enabled us to move the modeling significantly forward. One of these you can see on the screen in the center here. This is the ability to handle two solid states, okay? This means two different crystalline states of a compound, or an amorphous state and a crystalline state, or a salt and a non-salt. So this is what we mean by solid state. Okay, next slide, please. Added around this are a number of other models, which I will major models which I will describe from top left round clockwise. So the first is the salt surface pH model that I've already mentioned. This is one major addition to the tools. The second is a cyclodextrin binding model, which allows us to model solubility, permeability, and free fraction interplay. The model is not specifically geared towards cyclodextrin. It can be used for binding to other excipients. The third major addition is on the right here, which is the dynamic bile salt model. This enables us to model time-dependent concentrations in total bile salt in the GI tract and in different regions of the GI tract, and with inter-individual variability of those concentrations. So if you look at the purple line, which is a simulation for the duodenum, you can see that the concentration changes with time, and this is linked to the phases of the migrating motor complex. Roughly in the center, you can see a spike in the concentration, which is associated with gallbladder kinetics after taking a meal, in this case at the 4-hour time point. So this model is a major step forward in terms of handling bile salts. It does serve as a platform for further developments, including looking at individual bile salts and adding in other components that impact solubilization in the GI tract, such as fatty acids and so on. Moving on, we have done major extensions to the way we are able to handle fasted and fed simulations with the food staggering stroke custom trial design tools. So with these new tools, you can specify meals given independent of dose, and that we have smooth transitions between fasted and fed state during the simulation, so you can switch between fasted, have a meal, continue for the duration of the fed state, and then revert to the fasted state, then take another meal, and so on. And this seems to be the ability to model the impact of a meal for certain drugs can be very important, even if you dosed in the fasted state, because typically a meal may be given at 4 hours, and you can see in the little graphic that there is a spike in the concentration of the drug in the systemic system associated with the meal. And you can see this in certain, if you look at individual profiles of subjects monitored in a clinical trial. And the final addition I wanted to mention is the nucleation model, which is based upon classical nucleation theory. This we have been able to parameterize now, at least for one compound, based upon modeling of in vitro data. So this is a major step forward. Overall, most of the features that I've described on this slide are not available in other commercial software. Next slide, please. Many of you who are familiar with Simcyp will be familiar with this slide, where we describe the separation of systems information from drug information. So systems refers to the physiological data and its variability and population differences. And then we put the information together within a trial design, apply the mechanistic algorithms, and make predictions of population PK or PD. Okay. So in the context of what we're talking about today, the mechanistic algorithms are centered on some of the features I've already described in terms of the PPB model and the other tools. Wrapped around this whole core, if you like, are wrappers, and these include physiologically-based IVIVC, which we're developing further at the moment to deal with population-based IVIVC, individual IVIVC, and more mechanistic IVIVC in terms of dissolution, making use of the diffusion layer model, which is a major departure from using in vitro dissolution as the a reference point. We've also recently added, if you look bottom left, global sensitivity analysis tools. These greatly extend the existing tools, which were local sensitivity analysis, enables you, for one, to actually rank or the importance of the variables selected for sensitivity analysis, and then perhaps enable you to focus on those using local sensitivity analysis. And then we come to the virtual bioequivalence tools, which again are essentially a wrapper around the core that I've shown you. The additional information required here is within subject variability or inter-occasion variability, and obviously the definition of study designs that are required. Virtual bioequivalence, as many of you know, has significant regulatory support and interest. Okay, and this is exemplified by the slide here from a public workshop in May 2017. So on the back of this, for Simcyp version 20, we are providing a much enhanced and very comprehensive VBE trial design tool. So version 20 of Simcyp is due to be released later this year. Most of the common designs available will be available, as you can see from the list down here. You can see the various partial replicate, full replicate, and standard treatments, typical crossover at the top there. You will also be able to do parallel designs and also customized crossover designs. Within the PBPK framework, within subject variability or inter-occasion variability is added to physiological parameters, which are selected on the screen, and you then are able to define maxima and minima for these, and also their distribution, log normal or uniform. The bioequivalence analysis itself will be done in Phoenix. Okay, so there is a connection to the Phoenix Certara Phoenix software, and the actual BE analysis is done in Phoenix based on the outputs from Simcyp. Moving forward a little. The running theme that runs through this presentation is the informing of the PBPK or PBBM modeling, as I think people like to call it these days. That this modeling should be informed by in vitro experiments, either in a qualitative sense or a quantitative sense in terms of parameter estimation that can be there. Estimation of parameters that can be taken through to the in vivo PBPK modeling. So for this, we have the SIVA toolkit, and we're using this toolkit. We can model various in vitro experiments, which I'll describe in more detail shortly. These consist of in vitro dissolution, solubility, and also in vitro cell culture experiments. So the modeling of these is it enhances your understanding of perhaps your formulation, enables you to gain some confidence in the modeling, and enables you to estimate and or confirm existing parameters that you have obtained from other sources. And conversely, the design of in vitro experiments can also be informed by the PBPK modeling itself. So, for example, if you want to try and establish what the biorelevant concentrations of either your compound or perhaps an excipient are, you may wish to run some PBPK simulations first and look at the ranges, concentration ranges in the gut lumen that the model is predicting. You can then use that information perhaps to inform your in vitro experiment, and I'll touch on this further later on in the presentation. So this can be a two-way thing, a two-way interplay between the modeling of in vitro experiments and the PBPK modeling. In terms of the in vitro modeling, we've also have recommended a workflow in the sense that you stepwise establish or estimate the parameters required, in this case for the biopharmaceutic modeling. So step one here, for example, would be to confirm and or estimate the parameters required to capture aqueous phase solubility modeling information, so pH-dependent solubility, if you like. Once you have those parameters, you could then move on to look at biorelevant solubility modeling, such as passive or fessive, to make sure that you are able to predict accurately for example, passive or fessive solubility. You can then fix these parameters and then move to your dissolution modeling. And this may be modeling of USP2, as we've shown here, or it may be the modeling of a transfer experiment if you have done these in certain special cases where this kind of modeling experiment is required. So just to emphasize, the SIVA toolkit is a completely standalone software for modeling in vitro experiments. In terms of dissolution experiments, you can currently model experiments done in USP2 and microdis systems. You can do serial dilution or handle serial dilution models. Essentially here we're talking about media change or pH change. After a certain incubation time, you may switch from a gastric to an intestinal medium. Dynamic transfer model, which we've shown in the graphic on the left, the transfer experiment here. And also a two-phase model, which is a single vessel system with an absorptive phase. So one example of the application of these tools from in vitro experiment through modeling of these experiments with SIVA and then subsequent modeling in Simcyp is this example I've shown here from the literature where virtual bioequivalence and safe spaces were identified in terms of dissolution for the case example, naproxen. So the approach taken here was a PBPK model was built using a middle-out approach. For any of those of you who are not familiar with this approach, I recommend reading this Simcyp consortium paper from Shedley et al. From 2018, where the recommended processes and steps that you should take and current practice are described in some detail. The established model was then verified against clinical data, and then various dissolution scenarios were modeled, including the different compounds or formulations that you can see on the left down here, such as the free acid formulation, sodium salt, and the other formulations. Model-based analysis of the in vitro dissolution was performed using SIVA, And then further clinical trial simulations were carried out using the parameterized mechanistic models that were parameterized from the modeling of the in vitro dissolution. So this is not the case of simply putting the in vitro dissolution profile into the PBPK simulator. They're essentially a mechanistic model of the dissolution, been parameterized from SIVA and then input to the system. Subsequent to that, some typically designed VBE trials were performed with a typical crossover design, and the inter-occasion variability was added to the critical physiological parameters. And what we were able to do here was to identify, in this particular case, a safe space for dissolution, essentially within which the in vitro dissolution can be used, the ranges of in vitro dissolution where you expect bioequivalence in terms of the clinical outcomes. Focusing now on a little bit of detail of some of the new tools, and I won't spend too much time on the specific details, but I've picked out a few things of interest for you. One of these is the particle size distribution tools, which now include an import function where you can directly import particle size distribution from an instrument such as a mastersizer or another instrument. In these cases, then there is no need to summarize the data and or perhaps lose information simply by using D10, D50, D90 characterization of your PSD, although in some cases that may be sufficient. So essentially, with the import function, we import the data, we display it where I've indicated with the blue arrow. So in here there were 45 bins, particle size bins imported with their volume fraction associated. And you can see at the bottom here a display of the import. Now this is a large number of particle size bins which may cause problems for simulation in terms of simulation speed. So the tools that we've added now enable you to automatically map to a distribution without losing information, without losing mass, or for example, to a smaller number of bins. So here I've mapped the original 45, top left, down to 20 particle size bins. And there are a number of options here that you can use, such as choosing what type of distribution, where it is log distributed, normally distributed, uniform distribution. And you can also choose to interpolate or not interpolate in terms of bins that may exist between the measured points that you obtain from your measurements. So this is quite a powerful tool for mapping a PSD. In terms of the two solid-state tools, this slide briefly summarizes what is available. The dissolution rate now for fine particle dissolution is actually where you have two solid states coexisting, let's say two polymorphs. Dissolution rate is now calculated summed over the particle size distributions for both different solid states if they are simultaneously present, and for each bin that's defined for each of those solid states. Okay, so the tools are available to input different PSD distributions according to the solid states present, which may be present in some formulations, and I'll come back to why that's of interest shortly. So bottom left here, you can see I've activated model 2 solid states. You can enter aqueous phase solubility. So here is the intrinsic solubility for one solid state. You can then switch to another screen and enter the solubility of, let's say, a different polymorph. Okay, so you can enter this information into the system, and the model will then automatically apply according to what solid state is being dissolved or growing in terms of precipitation. On the right here, you can see that we have options for precipitation, okay? The model is able to simultaneously precipitate to two different solid states if conditions are correct for that to happen. Typically, you would maybe, if you, for example, you are modeling an amorphous formulation, you may get precipitation only to a crystalline state, in which case you could perhaps switch off the amorphous precipitation option and then purely precipitate to the crystalline condition, or vice versa, okay? So those decisions would be needed to be informed by in vitro experiments. The other great benefit of these models is that you can ask what-if questions. What if there is precipitation only to this solid state or that solid state, or what if there's perhaps precipitation to both, which can happen, although it's simultaneously, although it can probably quite rare. So to come to an example, this example is with Tacrolimus, which is a well-known immunosuppressant, first approved more than 20 years ago. The innovator product for this is Prograph, which is an amorphous solid dispersion, okay? Tacrolimus is poorly water soluble, and hence the reason for formulation as an ASD. It is also neutral, i.e. non-ionizing, and it's a BCS2 compound, so low solubility and relatively high permeability. As I said, the commercial formulation is an amorphous solid dispersion. There are actually a number of generic formulations which contain amorphous drug, and one of these, the Accord formulation, has been found to be susceptible to crystallization over time during storage under stress conditions, relatively humid conditions. So one question that you may wish to ask is what degree of crystallinity may render the formulation bioequivalent to the fully amorphous, i.e. the intended formulation. So there is a paper on this in the literature from Professor Lynn Taylor's group. I've cited the reference down here. Part of the study here involved in vitro dissolution studies at various volumes of fluid in a USP1 non-micellar buffer. And you can see at the top here that they undertook these experiments in 3 different volumes of fluid, 450, 140 mils. And you can see on the 2 right profiles that all of the formulations except the Prograph precipitate after a certain time. There's a rapid initial, relatively rapid initial dissolution, and then all of them precipitate after a certain time. So one question you might want to ask is which in vitro experiment or condition is relevant to in vivo? And if you chose to take one of these in vitro profiles and provide it as input to direct input to a PBPK model, which one should you use? Now that's quite a difficult decision without some thought. So is there an alternative approach? Well, the approach we've taken is to use mechanistic modeling to calculate dissolution rather than directly inputting in vitro dissolution profile into the PBPK model. So to do this, we exploited the 2 solid state models, and I'm going to step back because I missed something here. These profiles that you're looking at here essentially have different extents of crystallinity in the formulation. So if we look at the 450 mil simulations on the left, dissolutions on the left, the formulations dissolving to the greatest extent have the highest amorphous content. As the amorphous content drops and the crystalline content increases, the rate and extent of the dissolution drops down. So you can see that for the 100% crystalline formulation, this has a maximum release or dissolution of 30% in the 450 ml media. Okay. So in order to capture this, we use the two solid-state tools. So we're able to express, as you can see at the top here, the fraction of a solid state in a given dose. And I've picked here 30% in solid state 1, and clearly then there's 70 in solid state 2. The amorphous form has more than 25-fold higher solubility than the crystalline form, as you can see on the right-hand side here. So this information is input into the different solubility sections of the simulator. Another thing to note is that these formulations were formulated with approximately 5 milligrams of HPMC, which I'll come back to in a moment. So a PBPK model was built stepwise. IV data were available. So this obviously helped with the disposition. Tacrolimus also has very high concentration-dependent red blood cell binding, which we found was very important to include within the simulations. Also very useful in this case, an oral solution clinical study was available to verify the models prior to using them to apply to ASD modeling. The compound also has quite high first-pass gut metabolism. And as I've already mentioned, we applied the mechanistic dissolution layer model in these simulations. One of the issues we have to deal with is what is the precipitation risk expected with tacrolimus, with these formulations. And these data that you can see here give you an idea that the induction time for tacrolimus crystallization at the amorphous concentration or amorphous solubility limit are greatly extended in the presence of HPMC. Okay, so that in the presence of HPMC, the induction time is almost eliminated with respect to expected absorption times in vivo. To back this up a little, I ran some simulations, or we ran some simulations with using the dose of HPMC with the PBPK simulator. So we did a standard Simcyp simulation with 5.5 milligrams of HPMC, and then looked at the time concentration profiles within the fluids of the GI tract. And you can see here that the concentrations remain high throughout the passage during the GI tract. Okay, you have to remember here that the HPMC is transiting down the GI tract roughly with the formulation. So the formulation or the dissolved compounds will be at highest concentration roughly at the same time as the HPMC. Okay, so these concentrations are relevant to the inhibition effect on precipitation. So when we ran the PBPK simulations with 50 subjects in healthy volunteers and the North European Caucasian population, the simulations are predicting that the degree of crystallinity has a significant impact on the simulated PK. There are no human data yet available to verify this model. However, there has been a reported study in dogs where, although they didn't examine such a wide range of crystallization, there was found to be a significant impact on exposure, where, for example, a 50% crystalline initial formulation was dosed to the animals. So these these results qualitatively roughly reflect that situation, the results here. So we performed a two-way crossover, virtual bioequivalence, to look at this, evaluating the metrics Cmax and AUC in healthy volunteers. So along the bottom axis here, we have test product crystallinity, so increasing degrees of crystallinity. The TR ratio here is basically the reference is the fully amorphous form. And you can see from this we've identified that bioinequivalence arises as soon as the formulation reaches between 10 and 20% crystallinity. So in this particular case, it's probably likely that no extent of crystallinity really could be permitted in the commercial formulation. In this particular example, the VBE analysis was performed in R. So the mechanistic modeling in this case removed the need for potentially complex in vitro dissolution experiments with an absorptive or phase or component. So essentially we moved away from trying to choose which in vitro dissolution profile should be input to the PBPK model by mechanistically modeling the Tacrolimus disposition. We also looked at the relevance of in vitro experiments here in terms of concentration. So we ran simulations with precipitation blocked, where you expect to get the maximum concentration of dissolved tacrolimus in the system. And we found that this would be in the jejunum 1 of the GI tract. And for 100% amorphous formulation, the concentration never exceeds 6 micrograms per mil, which is significantly less, or certainly within the stable zone of the profiles above. If you look at the final metastable concentrations that I've indicated in red at the top here, you can see that it appears that it's extremely unlikely that you will get the high concentrations that you get, particularly in the lower volume in vitro experiments. You're unlikely to get them in vivo, and this is essentially linked to the high permeability of the compound. The second example I wanted to show you is an excipient binding case study. This is a study undertaken with a compound from a Simcyp consortium member. It's a BCS2 compound again with low intrinsic solubility and high Peff. It has low basic pKa as well, so it does carry a precipitation risk when the drug transits from the stomach, fasted stomach, to the small intestine. In order to mitigate this risk, the drug was formulated with 8 grams of cyclodextrin with the aim to increase solubility and reduce precipitation risk. When a clinical study was undertaken, it was found that the AUC and Cmax were reduced significantly, which was an unexpected result, and Tmax was increased significantly. So they came to us to look for an explanation, and we developed some PBPK models to look into this using the new Excipient binding model tools. So in order to use these new tools, you can run simulations effectively where you indicate, if you look top right, the dose of the excipient. Okay, in this case it's in the inhibitor 1 slot. So here I've got 8 milligrams of, or 8 grams of hydroxypropyl beta cyclodextrin. We then run the simulation in the same way as we run a normal simulation, and you can get time concentration profiles of the cyclodextrin. We can then link that with an appropriate model to the solubilization of the drug using the equation that you can see on the left here. And this is one reason why it's essential to decompose solubility into its components parts so we can mechanistically capture these things. The second thing that you need to run this model is the mechanistic permeability model, which automatically gives you regional permeability differences within the GI tract. And you have to use a default setting where free aqueous concentration is driving the membrane permeation. Okay, this can only be done with the MEC-Peff model within ADAM. Okay, and this requires knowledge of the fraction unbound in the mucus water layer, which we get from the solubility equations. Key input to this model is P-trans 0, and this is best obtained from modeling of in vitro cell line experiments. And these tools will be available in the next version of SIVA, due out later this year. So you'll be able to estimate P-trans 0, which is the key input to the models. The pharma company were able to generate solubility data in the presence of varying concentrations of the cyclodextrin. We then fitted a one-to-one binding model using a single binding constant to explain these solubility data, okay? And then this was input to the PBPK model that you can see on the right here. So when we ran the simulations in the presence and the absence of the cyclodextrin, the simulations predict that the binding to the cyclodextrin significantly reduces the Cmax and the AUC. So this is a comparison of the black line in the presence of the cyclodextrin to the green line when no cyclodextrin was present. So the simulations were consistent with the findings of the clinical study, and in fact, if the modelling had been done in advance, this could have been anticipated prior to doing the study. The underlying mechanism of this is that the effective permeability is severely reduced in the presence of binding of the compound to the cyclodextrin. So you can see the trough in the top plot here in the permeability in the jejunum 1, which at the highest concentration of cyclodextrin gives you the minimum permeability. So there's a more than 5-fold reduction in permeability. There's no change to the actual membrane permeability here. This is an effect that I'll describe shortly. In terms of flux across the mucous water layer, this is actually increased because of the higher loading because the excipient drug bound to the excipient can also transverse this layer. So this is actually increased. But the major mechanism underlying this is a change in the free fraction, which you can also see bottom left here. So the dominant effect in this study is the free fraction is hugely decreased, and that's reflected in the Peff at the top. And this model could also be applied to binding to other excipients. In terms of evidence for this type of model, there is some very nice work from the laboratory of Eric Dahan. In this case, they used danazol in rat perfusion studies in the presence of cyclodextrin, and you can see the trend in the reduction of Peff as the cyclodextrin concentration increases. With this particular compound, you could also do sensitivity analysis on dose simply by selecting dose of excipient and then selecting the range that you require, and then using the sensitivity analysis tool, look at the impact on plasma profiles and AUC and Peff, Cmax and Tmax and so on. With this particular compound, even with small amounts of cyclodextrin, you actually get a reduction in exposure, okay? But in principle, these tools can be used to estimate optimal excipient dose, where you're looking at the balance between increase in solubilization and reduction in permeability. There's one example on the left here from in vitro experiments, okay, in terms of flux. In an in vitro system, so there's a clear optimum flux linked to the cyclodextrin concentration. And on the right here, I've simply shown a hypothetical analysis for a hypothetical drug using the Simcyp sensitivity analysis tools here. So in principle, this can be applied to excipient dose optimization for your compounds. Moving forward quickly, we have added a salt model and surface solubility models to version 19 of Simcyp. Surface solubility refers to particle microenvironment pH and solubility, okay? And I'll come back to that briefly in a second. For handling the salts, you can handle drug formulated as a salt or not formulated as a salt, but with some interaction with endogenous ions. And we can also handle common ion effects, such as with a chloride salt with endogenous ions. And we're able to capture in the simulations time variance in chloride concentrations in the GI tract. So, for example, if you take a drink of water, the initial chloride ion concentration in the stomach is diluted. The models can also handle precipitation to either salt or free base. Similar to Tacrolimus, or analogous to Tacrolimus, you can look at disproportionation, which can occur during storage for salt formulations. So in principle, you can use the same tools here, where you express the fraction salt and the fraction free form in your initial formulation. And the model underlying this is obviously solubility product, which is essentially controlling the solubility for a weak base in at the pH range below the pH max that I've shown in the slide here. So there are various potential advantages of the surface pH model here. We've looked at haloperidol 3 base and verified the models in vitro. Okay. You can see that surface pH here differs significantly from bulk fluid pH. And when we apply this in terms of dissolution, you can see that without the surface pH model, the model is in error by orders of magnitude in terms of pH rate, because we have a log scale on the left side here. In terms of salts itself, where we also have the surface pH model for the salt, you can see in this particular case deviation from bulk fluid pH above pH 5, deviation of the surface pH. When we apply this to dissolution modeling, dissolution modeling, you can again see major differences in terms of dissolution rate with and without the surface pH model. And the dots on all these plots are clearly the measured experimental data. So the take-home message here is that to accurately model dissolution, it's very important, or can be very important, to consider surface pH and solubility for both free forms and salts. Okay, so just to summarize, I've been through some of the recent additions. I've been through some of the thinking behind what we're doing, particularly in terms of coupling in vitro experiments with PBPK modeling. And also, I want to emphasize that the mechanistic models, many of which I've described here, are part of the core of the system, and that the wrappers around these tools are, in a sense, reliant on these new tools and algorithms, and also on their future further development. I've given you a couple of examples based on using the new tools that we have, and I've covered the salt and surface pH models briefly. Just a few acknowledgements here. Funding for much of this work has come from the Simcyp Consortium, of course, plus also the US FDA, and I've listed the grant here. I'd also like to acknowledge the input of all of my colleagues here that I've listed here. Also, for research purposes in academic and not-for-profit organizations, the Simcyp simulator is freely available, provided you complete relevant workshops. So this is something which may be of great interest to some of you. All webinars are recorded and stored on the Zatara system, and I've also here provided links to the upcoming workshops. So thank you very much for your attention, and please let us know if you have any questions.
Wonderful. Thank you so much, David. Looks like we've got some questions already from our audience. Folks, just put them in the Q&A box, and we'll answer as many as the time permits. First question, David. Someone asks whether the dynamic bile salt model is available for pediatrics.
No, it's not at present. It needs some reparameterization in order to be used.
Someone also wants to know, can we compare the physiological variations in bile salt concentrations in adults and pediatrics on the absorption of some narrow therapeutic drugs?
This relates back to the previous questions in the luminal bile salt concentration. The dynamic model is not available for pediatric. So the comparison is difficult. Yeah, so if the questioner wants to follow up on that question, could you contact me, please, by email?
Perfect.
I may have some further insight. for that.
Someone says Tacrolimus is a substrate for transporters. Was that taken into account in the model?
No, we didn't include that in the model here. It's something that we could add to the model in future. The real purpose of the Tacrolimus study was to exemplify what can be done with the tools. We haven't yet completely finalized all aspects of the model.
Got it. Another question about the Tacrolimus model. How different was the 2 solid-state model of Tacrolimus to the first-order absorption model?
You simply cannot take into account the differences in the degree of crystallization in the formulation with the first-order model. If you have all the clinical data, you could just simply fit a Ka to each formulation separately, but that gives you no way of anticipating the behavior of these different formulations. The benefits of the mechanistic model are that you can, in this particular case, are that you can separate out the dissolution of the 2 different solid states. The crystalline obviously dissolves extremely slowly. The pure crystalline formulation in the simulation still has an FA of around 0.5, 0.6. It's just much more slowly absorbed. So in principle, you can fit a first-order model to account for this, but you would need that bottom up. You wouldn't be able to do it. You'd have to have the clinical data in order to match it.
Someone asks, when will the next version of the SIVA toolkit be released, and what will be included in it?
The next version of SIVA will be SIVA 4. The biggest addition to SIVA 4 will be the ability to estimate P-trans naught for use with the MEC-Peff model. This is something I mentioned in the presentation. In the simulator we have tools to predict P-trans naught automatically from log P, but when you plot out the data log P versus P-trans naught, whilst there is a reasonably strong correlation, there is a large scatter on the information. So we do on the plots. So we do recommend this experimental modelling approach. So using experimental P-trans naught, we have had better predictions of loci-gut Peff. So in perfusion, in situ perfusion study Peff. So we would thoroughly recommend people taking that route. And I should emphasize, P-trans naught is not the same as in vitro PAP. It's a component of PAP, okay, in your in vitro system. SIVA 5, which we're hoping to release towards the end of the year, will have additional biopharm tools related to some of the models that I've mentioned here. Excuse me, I've got a very dry throat.
It's okay. Looks like we've got one final question.
Sorry, can I just add, this will include the
of course.
ability to use the KSP salt model. The nucleation model could be parameterized in SIVA. The excipient binding constants can be estimated. And the new PSD tools will be added that I described in the presentation.
Looks like we have one final question from our audience. Someone wants to know, how could you handle virtual bioequivalence for a compound that's a CYP2C9 substrate, which is subject to genetic polymorphisms?
Could you repeat that, please?
So someone brings up the case of a theoretical drug that's a CYP2C9 substrate, and this is CYP2C9 is an enzyme that has a lot of genetic polymorphism. So how would you handle demonstrating virtual bioequivalence for such a compound?
Well, the simulator has a built-in information for these different polymorphisms. So, well, there's two options. You would either have to screen, if in a clinical trial you screen your subjects for these polymorphisms and you select those, for example, which are extensive metabolizers, you could then adjust the simulator to, for example, be 100% extensive metabolizers rather than using the default sort of population proportions for the different polymorphic expressions. So, yeah, that would be my answer there.
Great. Thank you so much, David, and thank you so much to our audience for all those great questions. We have a few short announcements before ending our webinar. The next webinar in the series will take place on February 13th when Roman Cassiano will present The Rare Disease Drug Dilemma, Great Value, High Price, Limited Access. On March 12th, Dr. Sebastian Pollack will present Virtual Bioequivalence in Dermal Drug Development using in silico modeling and simulation. Finally, on April 15th, Dr. Christian Moss will present Integration of QSP and Organ-on-Chips for Translational Pharmacology Applications. You can register for all webinars in the series by visiting certara.com/webinars. On behalf of Certara, I would like to thank you for attending today's presentation. This concludes the webinar. Goodbye and have a great day.